Good evening, everyone, and welcome to the Florey's evening lecture series. I acknowledge that we are standing on the land of the Wurundjeri people who have been custodians of this land for thousands of years. My name is Eloise Holmes, and I look after the philanthropists who support the Florey in our crucial work in brain research. You may or may not know it, but the Florey is actually a not-for-profit and a registered charity, and around 9% of our annual revenue comes from the support of individuals and philanthropic trusts and foundations who contribute to our work. So if you're interested in supporting the Florey in any way at all, please feel free to speak with me at the end of the lecture or with my colleague Jane, who's actually been welcoming you as well as you have arrived tonight. At the table outside, you would have seen we have copies of our newsletters and our annual report from 2017. We also, and you're free to take those copies of those. We also have a what do you think sheet that we would love you to fill in to let us know what you think of tonight's lecture, as well as any other feedback you may have for the Florey. Thank you for choosing to spend your Wednesday night with us to hear about the current and emerging trends in the treatments for Parkinson's disease, which will be presented by Associate Professor David Finkelstein and his colleague of many years, Victor McConvey. Part of it, our aim at the Florey, is to share with as widely as possible with the public information and findings from the work that comes out of our labs. And those labs are actually located in this actual building, as well as some in our Heidelberg campus attached to the Austin Hospital. Before I introduce our speakers, may I please introduce that you put your phones on silent mode or turn them off. The lecture will be around 45 minutes, and there will be time to ask questions of David and Victor. David Finkelstein is the head of the Parkinson's lab at the Florey. He has led many research projects and has authored over 150 research papers in peer-reviewed journals. David is chair of Parkinson's Victoria, so his work is based a lot in and amongst the community. He advocates for more funding from government grants for Parkinson's research and support for Parkinson's services. Victor McConvey has been a nurse for over 29 years, and he has worked in the area of neurology for the past 20 years. He is currently a clinical nurse consultant at Parkinson's Victoria, and he has worked in clinical management and service development positions in Australia and the UK. He's currently chair of the healthcare professional section and the chair of the task force on palliative care of the International Parkinson's and Movement Disorder Society. Like David, he has presented at conferences worldwide about various aspects of Parkinson's. Victor will be the first to present, but I'll request David to come up because he will put some context around the talks that they will be delivering tonight.
Thank you very much for coming out tonight. Welcome to my home. To cure diseases, to understand diseases, you have to understand what's happening to people. Now, Victor is an example, probably of the world-leading example of a nurse who is involved in the community. He's known throughout Victoria and nationally and internationally. One of the roles which we do at the Florey is to translate our science so that this can be explained to people. Knowledge is power. The really important part that Victor does is he not only educates nurses, but he also educates doctors. We've got a very big program educating. We want our doctors in Victoria, and that's where we've got our mandate, to be the best in the world. We want you to have the best current therapies, and that's what Victor is going to be talking about. I'm going to be talking about the future and what the future holds. This organisation is another voluntary organisation which we have a collaboration with at the Florey, so I can wear two hats. One is my day job and one of which I volunteer at Parkinson's Victoria. It's a great organisation which all it does is care about people with Parkinson's and Parkinson's-like diseases. So Victor, you'll see in the flesh, and he'll talk about practical things. I'm going to talk about ideas and concepts and new things which are going to happen in the next few years. So Victor, please.
I'm going to do the bedside bit, but I'm going to start off with a little bit of history, first of all, because what I must impress upon you all is Parkinson's has been around for a long time. We've got good descriptions of people with the signs and symptoms of Parkinson's right back to ancient Greek. And so right the way through time, when people have been describing the symptoms that are being experienced by our communities, we can see Parkinson's and people describing the tremor, the stiffness of movement throughout time. So it's not a new condition. But what we can reflect upon is the research into better treatments and getting towards maybe ways of preventing it from progressing has happened probably in the last 10 years significantly, certainly within my career of working in neurology. So probably the Parkinson's, how it got its name. A fellow called James Parkinson, who was a neurologist, well, he was a physician, geologist, and a political agitator, found these people wandering around London, got them down, described their symptoms, described it as paralysis agentatus or the shaking palsy. He never realised it was going to be called Parkinson's disease because it wasn't up until this fellow, Charcot, was actually writing in Paris doing a similar body of work, and he realised it's the same condition, and the name Parkinson's disease sort of stuck from then on in. But one of our earliest treatments for Parkinson's actually was developed in that ruined hospital there, which is in Sri Lanka. When way back in the 14th century, the physicians working in this hospital identified that they could use extract of mucuna beans, an Ayurvedic medication called mucunapurins, which we know it as today, to actually treat people who presented with slow, tremulous movement. The active constituent in the Cinemed and the Matapar drugs used to treat Parkinson's today comes from that very same product. So way back in the 14th century, some of our smart minds were putting things together. What we know today is Parkinson's is the second most common neurological illness we'll see, dementias being the most common. We probably could comfortably fill the MCG with people living with Parkinson's. When you think about that many people in Australia, about 100,000. 83,000 is probably a fairly conservative estimate. The peak age of incidence of Parkinson's, 80% of people are diagnosed around about the age of 65, a little bit older. But we must also remember this condition is also seen in younger people. So about 20% of people are diagnosed before the age of 60 and about half of those before the age of 40. So it's an illness that we see in that broad spectrum of life in Australia. Men are slightly more prone to Parkinson's than female, but only by about 1.5%. Parkinson's is caused by a loss of dopamine-producing cells within the brain, but also within some other organs of the body. When we don't have enough dopamine, we actually can't move and modulate our motor coordination as effectively. And we lose some of the ability to carry out those automatic movements. In the brain, the largest concentration of dopamine-producing cells in an organ called the basal ganglia, which is very, very deep brain. And the picture we have in the middle is a couple of cross-sections of deep brain. One we can see which is stained with some black pigment, which is dopamine, because when it's produced, it's black in colour. The other one we see, blackness is washed out. We can make the assumption that person had Parkinson's. Further examination, we'd actually see these donut-like structures, which are the Lewy bodies. So Parkinson's is a Lewy body disorder. And that's basically a clump of protein called alpha-synuclein, which has stopped those Lewy bodies, stop those Parkinson's cells from producing dopamine. We don't know why people get Parkinson's. The cause is unknown in 90-95% of cases. There's a very small and very rare percentage number of people with Parkinson's which is familial or genetic. There's about 17 different genetic mutations that are associated with Parkinson's. But I can't stress it's incredibly rare when we do come across these people. There's lots of discussion about environment. I know David will touch on environment. Risk factors in environment, exposure to pesticides, drinking well water, heavy metals, head trauma and repeated head trauma, and amphetamine use. But we haven't actually identified any one particular trigger for Parkinson's. Other than one very unique situation where we found there was a batch of heroin in the San Francisco Bay Area contaminated with a chemical called MPTP. We saw rapid onset of Parkinsonism, which allowed us to isolate a molecule which can actually be specifically toxic to dopamine-producing cells, and we still use that in current research today. If you ever want to have a cracking read, Google Essay on the Frozen Addicts. That's a really interesting read. There's lots of school of thought thinking that might be your environment plus your genetic makeup that might contribute to developing Parkinson's. But there's much more work to be done in that particular space. And interestingly, if you smoke cigarettes, you're less likely to get Parkinson's. I'm not suggesting that buying a packet of Benson & Hedges is a prophylaxis. And a smoking-related disorder is probably something that we really wouldn't want to experience. So, again, it's an interesting phenomenon, and it is an avenue for some of our future research, looking at what happens when we expose the brains to nicotine, what happens to dopamine. But some interesting research that we were able to partner with the Florey to do was looking at a heat map of Victoria and thinking, is there any hotspots of Parkinson's? And what we saw in the Wimmera Mallee and Northern Grampians region, there was about a 2% increase in the incidence of Parkinson's. There was this automatic jump to conclusion, oh, that's clearly pesticide exposure. But we're not 100% sure. We just don't know. And certainly that research has actually really been a trigger for asking many, many more questions. And for me as a clinician who works in service development and works to improve community knowledge of Parkinson's, has given me some priority areas where I need to concentrate my efforts. So talking to GPs, running GP seminars, running community seminars, talking to hospitals about commissioning more services for people with Parkinson's is certainly something this research has been very important in enabling us to do at Parkinson's Victoria. But getting that Parkinson's diagnosis, we can truly definitively diagnose your Parkinson's at post-mortem, which is too late. We'd like to be able to diagnose it much sooner. The reality of life now is the diagnostic phase is down to the skill of the doctor that you see. If you present with textbook symptoms, which is maybe some hand tremor and some slight walking changes on one side of your body, we might quickly diagnose Parkinson's. If you present to your neurologist and you've got some vague pain in one shoulder which is getting a bit stiffer, we're just going to think it's a shoulder injury. We're not going to think it's Parkinson's. Frozen shoulder as a presentation of Parkinson's is documented. But your GP is probably going to send you to a physiotherapist, then to an orthopaedic surgeon. So for many people with Parkinson's, that diagnostic phase is about 2 years long. Comes down to the skill of the doctor that sees you. If you're in Melbourne, we've got some fantastic movement disorder neurologists. If you're in Mildura or Warrnambool or Horsham, it's a very different picture. So where you live gives access to some of the physicians that you get to see. There is research looking into ways of better diagnosing Parkinson's, and occasionally we might ask you to participate in that research. There's a couple of current trials on. One is looking at a blood test, one's looking at some imaging that looks at dopamine transporter mechanisms, so they're ongoing at the moment. But for the fact at the moment it's a classic clinical diagnosis. Comes down to that doctor that sees you. And when you're diagnosed, what you feel will vary from being relieved, particularly if it's been a while since you've had symptoms, angry, shocked, disbelief. And sometimes there's actually a bit of a disconnect between the doctor that tells you you've got Parkinson's and you receiving that diagnosis. Often the instantaneously sort of thinking, the doctors are saying, I'm fairly sure that you've got Parkinson's. And sometimes they follow that up with, don't worry about it too much. In their world, it's a slow progressive illness measured in decades. But maybe in your world, who's receiving that diagnosis, that instant relief, by the time you get back to your car, is replaced with this realisation you've got an incurable neurological illness. So suddenly you get a bit distressed at that point. And we know there's a disconnect between doctors giving the diagnosis and patients receiving it. And that's some research that we've done at Parkinson's Victoria, so we're working to rectify that. But with our diagnostic tests, one's the blood test that's coming out of La Trobe University that's looking at a particular constituent of white blood cells that behaves differently when we're starting to accumulate that brain protein called alpha-synuclein. The other is a SPECT scan, which we actually inject you full of a radioactive isotope that specifically tags dopamine transporter mechanisms, and we can visualise the brain's transport of dopamine. In someone with Parkinson's, it's vastly diminished, so that luminescence is a bit diminished. They're probably not going to be diagnostic tools per se, but they may well support that diagnosis. Because what we know is that Parkinson's is you've probably had Parkinson's for some time before you get that diagnosis. We reckon you probably had it for about 15 years before you get a motor symptom. Before someone complains about your handwriting, before you notice a bit of a tremor, or someone sort of says to you, why aren't you swinging your arm when you're walking? You've had it for some time. There's some quite unusual symptoms that are evolving that particular time. Things such as loss of sense of smell, changes to the way you sleep. So when you get into your deep level sleep, when normally the body's affected by a state of sleep atonia where we don't move, you're acting your dreams out. So you might be kicking your bed partner, you might be screaming in the middle of the night if you're having a nightmare. Becoming constipated. Some blood pressure fluctuations where your blood pressure dips a little bit, so when you go from sitting to stand you feel a bit dizzy. And occasional some mood disturbance. And sometimes people's initial symptom of Parkinson's is actually low mood and depression. These things are often evolving 15 years or so before you get a motor symptom. And by the time you get that motor symptom, you probably have lost about 50% of your body's ability to produce dopamine. So you've had it for some time. So in the future, we might be introducing questions about these symptoms to our general practitioners and sort of saying, when you're seeing a patient who's just turning 40 or 45, we should be screening for these symptoms. And maybe in the future, if you're ticking a couple of boxes, we might send you off to have a SPECT scan or have the Parkinson's blood test. Because one of the hopes for the future therapeutic substances that David will talk about is a way of arresting or slowing progression of Parkinson's down. The earlier we can catch it, the better that might actually be. But the symptoms that we're familiar with, bradykinesia or slowness of movement, that's caused because the muscles are getting a bit stiffer, so we don't move as well. The size of our step starts to decrease a little bit, and it affects one side of the body more significantly than the other side. We often associate Parkinson's with tremor, and about 70% of people will have that sort of resting tremor, but not everyone will have a resting tremor. 30% of people with Parkinson's sort of have just a rigid akinetic or a stiff version of Parkinson's. And sometimes they get a bit frustrated when they talk to us and say, people don't think I've got Parkinson's because I haven't got a tremor. So 30% of people don't actually have tremor. The stiffness that we feel as clinicians is quite distinct. So if you're living with Parkinson's and you're sitting down, or you're seeing that neurologist for the first time, you're wondering why this strange man's not coming towards you to welcome you. He's just standing at his doorway looking at you in a critical, sort of appraising way. When you sit down, he sort of says, just relax your arm by your side, and he starts flinging your limbs around. What we're looking for is looking for those gait disturbances, so seeing the way that your steps changes. And when we start to fling your limbs around passively, we're actually feeling some quite interesting rigidity. It's called cogwheel rigidity. So it quite literally feels like we're pushing through some cogs, so it's a juddery sort of movement. And we're always evaluating that, so we're always feeling for that. Sometimes those muscles get a bit stiff, so our posture changes. We've all seen that classic stooped Parkinsonian posture. So we're sort of walking around and we're a little bit stooped over. In Australia, we've got really good physiotherapy and we're a physically active community. So often that's a later symptom to evolve. We're often sort of more physically upright. Or we've got a partner that's actually there behind us sort of saying, stand up. Some people's muscles get quite stiff and get quite cramped. So you might have some dystonic or some cramping changes. You've got stiff muscles, so every movement that you do throughout the day, even once we start treating your Parkinson's, is going to be resulting in more resistance. So you're walking against more resistance. It's like you've got a couple of kilos strapped to each foot. You're going to get tireder, you're going to burn more calories as the day goes by. So fatigue in Parkinson's is a very, very real thing. The timing of this lecture is just perfect, because usually fatigue will hit us about 3 o'clock in the afternoon. Then we wake up a little bit, then it comes back again around about 9 o'clock at night. It's to do with the normal human circadian rhythm. And micrographia, so handwriting changes. So as the muscles in our forearms get stiffer, our movements start to decrease, so our handwriting gets smaller and more spidery. That's a really interesting symptom, and we see that because people don't handwrite anymore. We're all on keyboards. So it's not until you actually go to sign something that you realise that your signature's often actually changed. But Parkinson's is a complex illness. There's also a lot of non-motor and autonomic symptoms as well. So Parkinson's will reduce your GI tract motility. It makes you constipated. Sometimes the food will sit in your stomach for a little bit longer, and that may well have a direct impact on the medication absorption. You might perspire a little bit more. You might notice you have unpredictable perspiration, particularly once you start taking some treatments. Reduced sense of smell, increased production of oil in the skin and the scalp, blood pressure fluctuations, so sitting to standing, sometimes become an exercise where you get a bit dizzy. Your bladder becomes affected. You don't become incontinent, but that nervous system pathway between your bladder when we stretch the muscles out and the brain sort of saying you might need to go to the toilet soon is disturbed. You just get the one signal. You've got to go right now. You're never going to know who's going to win MasterChef because you can't wait for that ad break. You've got to go. Dopamine is that chemical that's being diminished in its production. We need dopamine for normal sexual function. So libido starts to decrease as well. Sometimes we're sort of thinking when we get a bit older, it's a bit of age, but sometimes Parkinson's is also playing into that as well. There are some non-motor difficulties. Sleep difficulties persist, so that high propensity to act your dreams out. Unfortunately, the treatments we use to manage Parkinson's symptoms can make those nightmares more vivid. So imagine that's not a great combination. You're more mobile in bed, and the drugs we use to treat it make those dreams more vivid. We also notice that during REM sleep disturbance, the movements that you experience when you've got Parkinson's are often better than when you're awake. So how frustrating is that? You've had a terrible nightmare, you've kicked off the bedclothes, the doona's on the other side of the room, you wake up and you can't get out of bed to retrieve it because you're all stiff and Parkinsonian. How frustrating is that? Low mood and depression. We know the mood fluctuates with dopamine levels. We know also you're living with a neurological illness. You're allowed to feel sad, so there are reactive components to depression as well as changes in your brain chemistry which affect mood. We need to treat it carefully. Parkinson's is not a painless condition, but 80% of people with Parkinson's will experience pain. Living with Parkinson's also decreases your pain threshold, so you're more sensitive to painful stimuli, even if you don't have pain associated with the condition. Some cognitive changes. So multitasking becomes more difficult. Initially, it might just show up some problems finding the right words. When we get tired, we all have some word-finding difficulties. But in Parkinson's, it can be a bit more pronounced. A little bit later on, we find that complex tasks become more difficult. So multitasking becomes a little bit more awkward. So sometimes it's hard to manage external stimuli as well as maintaining a movement. Hallucinations can occur. Sometimes we can trigger some changes in the way we behave by certain drugs that we treat that are active in our brain. So there's a certain group of drugs called dopamine agonists that can make you want to gamble or increase your sex drive or make you want to shop or eat more. You're not aware these symptoms are evolving when you're on these drugs, but people around you might be aware that things are suddenly changing with you. Interesting. Take you off those drugs, those behaviours all go away. And hallucinations can occur as well, and they're usually visual. They don't mean that you've suddenly gone mad or developed schizophrenia or it's a harbinger that you're about to become demented. They're again just another symptom of Parkinson's that's unpredictable. It's not necessarily related to drugs. Drugs might reduce the threshold to hallucinate, but I work in the the Sub-Saharan African Task Force in Parkinson's, where in countries like Ghana and Cameroon we've got no access to drugs. My patients there still hallucinate. So we know it's a Parkinson's symptom. And sometimes the motor and the non-motor collide. We've got him distracted, we're in the room with some cameras, walk out the door, and he's experiencing a phenomenon called freezing. Can't work out how to get his feet to move forward. But by putting an external cue in place to focus that movement again is enough to enable to initiate that walking. So we know in Parkinson's, normal movement is in fact possible. But sometimes you just have to activate other parts of the brain to make that possible. So can you think that when you're walking and you notice your steps are getting smaller, I think I have to concentrate on taking bigger steps. We can probably do that for 3 or 4 minutes, but then a distraction comes along and we'll go back to taking smaller steps. Human concentration span's only about 3 minutes. With Parkinson's, it means you actually are going to get tireder because you're going to have to concentrate a lot more. That's a very important avenue that a lot of our treatment focuses on, is looking at neuroplasticity and actually sort of enabling you to move. So things such as dancing in Parkinson's, we're using the cadence of the music to actually move to, provides that external cue and actually provides something that's pleasurable to do at the same time. So our treatments for Parkinson's, the treatments are symptomatic. Unfortunately, we don't have any treatments that will stop or slow progression of Parkinson's at the moment. Treatments are mainly tablet-based. So the treatment domains are, we replace dopamine. That's with tablets like Cinemet, Matapar, Kinson or Stalevo. That's a form of levodopa that's refined from that mucuna bean that I focused on early on, given with some buffering agents to get it across the blood-brain barrier. So it's levodopa or dopamine replacement, it's active centrally. So all of those peripheral symptoms such as blood pressure fluctuations and constipation, we need to treat through another avenue. That dopamine's not going to fix those. We might use dopamine agonist medications to enhance the uptake of dopamine in the brains. We might use COMT inhibitors or MAOB inhibitor type drugs to change the brain's metabolism of dopamine down. So we're having that effect of actually replacing, enhancing uptake and slowing metabolism of dopamine down, with the end effect of actually replacing that or increasing that brain dopamine level. So some really good treatments that are available. But because they're tablet-based, they fluctuate. And we see these fluctuations. And one of probably the motor symptoms that tracks most from quality of life in Parkinson's is sometimes we no longer have reliable movement. When you're on, your tablets are working, you're back to moving well, but that tablet will wear off after a period of time. So you find that you move less well, the symptoms come back. So we need to take more medication. So frequency of medication administration and keeping adjusting doses is a feature of living with Parkinson's. So about every 6 months, you beat that pathway back to the neurologist and you sort of say, these are my symptoms. This is what needs to happen. We need to adjust things around. And so after a little while, we're going to have you on more and more frequent doses of medication. So when you've had Parkinson's for several years, taking drugs every 3 hours is not an unusual thing. If you've ever been on a regular medication, how often have you forgotten to take a dose? Most of us would have said, yep, I've forgotten to take a dose. I can't get through a course of antibiotics without getting at least 2 doses. And now when you've got Parkinson's, you're taking medication on time, every time, at very regular intervals. And sometimes you forget. It's okay, we can get around that. It's not terrible. It just means you might move slowly for a little while. We manage all of those things. Some ways around some of these fluctuations, we've got some continuous therapies. When you've had Parkinson's for quite some time, there's a very potent dopamine agonist we give as an injection that will give you more of a continuous therapy, or there's a form of liquid levodopa or dopamine replacement that we can give you as a direct infusion. That sounds good, but the direct infusion we have to give it to is into the gastrointestinal tract, so you've got to have a little bit of plumbing work done. a little bit of extreme body piercing with a jejunostomy tube popped in. Gives you that direct drip feed of dopamine, which means you don't have these highs and lows anymore. But another form of continuous therapy that's really emerging is deep brain stimulation surgery. Now, this is the one that's a little bit sexy. We hear a lot of stuff in the press, and out of all the treatments for Parkinson's, this is the one that actually gets the most attention in media. The way it works is it sort of changes that brain's electrical activity back to a more normal level. So it stimulates the underactive parts of the brain and short circuits some of the overactive parts. So bring us back to more normal sort of brain function. We've got new targets that are changing all the time, and the sophistication sitting behind stimulation surgery is changing all the time, making it better and better and better. We now know that a comprehensive assessment prior to surgery is one of the keys to success. So making sure that we know your Parkinson's intimately. That means you're going to see a lot of different healthcare professionals, as well as going to go into the MRI machine to map out your brain structures. So it's valuable surgery. I know some of you probably would have seen the press a few weeks ago about a sleep deep brain stimulation surgery. We think we might have found a biomarker which might allow us to do DBS while you're asleep, but we haven't got there yet. We've identified the biomarker, but we still need to test that. So there'll be some clinical trialling going on into the future in regards to that. So we haven't quite, you can't quite have it when you're asleep just yet, but soon. But another way to manage Parkinson's is to stay active. Increasingly, we're starting to see that exercise has an incredibly valuable role to play in managing the symptoms of Parkinson's. We think we change some of our neurochemistry to actually be neuroprotective when we're physically active. Some research suggests that the dose of exercise should be around about 300 minutes a week, and should be a combination of resistance aerobic and strength training. 300 minutes a week, I think most of us would probably struggle to do that. That's an hour a day, 5 days a week. And so what we probably would more likely say is do something that interests you, keeps you engaged, that you keep on doing. It might be a combination of maybe some dancing, some Tai Chi, and maybe some resistance training. But staying active is incredibly important, as is maintaining that muscle strength and muscle bulk. So that holds us in very good stead. There's just a few words to finish up with. Parkinson's should not prevent you from living well. One of the keys to living well with Parkinson's is doing what you are tonight, is becoming informed, taking control, and being a good, if not annoying, patient. Learning, information, stuff that you can take back to your treating doctors and probe and sort of say, but I want to know more about this. I've heard about this, let's have a discussion. And taking control of that medical process and not so much being passive. We're very good at being passive when we see doctors, because you walk in there and they've often made us wait. You sit there and we think they know best, but you live with Parkinson's. You know best because you're the expert in your condition. Only you'll be affected uniquely. So go in there and sort of say, I've got this symptom. Is it related to my Parkinson's or is it something else? So be annoying. Have a list of questions and refuse to leave until they've all been answered. That really annoys them. We like that. So I'm going to hand over to David now. But I work at Parkinson's Victoria. I could be contacted 9 to 5, Monday to Friday on a 1-800 number, and there's some information at the front. But I'll hand over to David now.
Thank you. We'll combine the questions at the end for Victor and myself. I forgot to mention this. If you are interested, there's a fantastic consumer conference which is in Kyoto, which is a really great place. So we are in a bit of a crisis. Some have said that we're in a pandemic. If the increase in the rate of Parkinsonism was a virus, it would be called a pandemic. The number of people with Parkinson's will double. So the community is rightfully clamouring for governments to do more, and so to support scientists and support clinicians. We've got a theme running through the rest of my talk tonight. Well, firstly, I'll go to Victor's theme, is that we live well. We do not accept that people with Parkinson's should not live the best life that they can. Our goal is to make people's lives better, and we're going to do it together. Clinicians, scientists, and the community. This is a new trend. Why are we going through this terrible increase in the number of people with Parkinson's? Well, it's a good news, bad news story. We're getting older. The number of people who are 65 is increasing dramatically, and that's the time in which Parkinson's kicks on. If you look up here on this graph, this is people start to get Parkinson's usually around the age of 60. And as we age as a population, the number increases. This is happening everywhere in the world, apart from in India, where the population is not aging, is not increasing as aging like the rest of the world. China has, the economic revolution has increasing lifespan in China, but not so much in India. So the world is clamouring for what? A cure. I am using this word here, and throughout the world, people are saying a cure is possible soon. That is a disease-modifying therapy. That's because we're looking at things in a completely different way than we had a few years ago. This is a worldwide community, which Victor's part of, being an international committees. I am by publishing internationally. The Florey is a very influential member of the worldwide scientific community. The Michael J. Fox, I'm going to come to some of their research in a little bit, but they've been extraordinarily influential, and that's largely funded by private donation. All that funds through Michael J. Fox. How are we going to get a cure? Well, it's obvious, money. The federal government in Australia is putting in what they can. We're saying it's not enough in Parkinson's Victoria. We say you actually have to give more. They're doubling the amount of money for research in Australia, but unfortunately not enough of it is going to age research, which I believe it should. So there's my political hat, and that's what we're doing in Parkinson's Victoria. We're trying to lobby government to say, hold on, look to the future, look to 15 years' time and look at your health costs and your health needs. And that's what this map's about too. Where are you going to put your hospitals? Well, I'd put one right in the middle, on number A. This is why we need community. It's not all doom and gloom. There's a lot of pharmaceutical companies putting in money, and they're putting in big money. $2.5 billion to get a drug into the market. And unfortunately, that's increasing as time goes on. I'll just explain a little bit about that, because you're saying, well, with all you smart people around, why can't you just get a drug into the market tomorrow? Well, firstly, we have to discover drugs. We then have to prove that it works. Then we have to then take it through all this preclinical testing to make sure it's safe. Then we go through multiple tests with people, and we try and do no harm. But there's been a big failure in the Alzheimer's field with bebimuzumab, where they sunk $4 billion into this drug, which didn't work for Alzheimer's. So large pharmaceutical companies have pulled out of the industry for a long time. So we traditionally, as scientists, have got money from government as well as pharmaceutical industry, and that's been retracted over the last few years. But the biggest thing is, as Victor has said, there's no blood test. It comes up to the clinical skills of your doctors. And that is holding us back. everybody says, well, I know what can cure Parkinson's. Well, everybody knows that marijuana does. Well, not so. If you look at the meta-studies, there are benefits of using marijuana for certain conditions, or marijuana oil, but there have been no studies which show that marijuana, for example. So this is a false lead. So scientists have to drive it, but you have to be cautious of where the information comes from. This is an example of why I'm cautious about clinical trials and how we have to proceed slowly. And even though the immense costs are there, we have to be very careful. Now, one of the aims of a study was to invent a new painkiller. Now, one of the side effects of marijuana, and that's why I bring it in, is that they had some analgesic properties. And so people thought, well, this is really good. We can use a natural compound and we will apply it to people and we will have a better non-addictive painkiller. And this chemical works upon the receptors in the brain, which cannabis does. Unfortunately, the trial started, it recruited 128 healthy people aged 18 to 55. They were paid about $2,500 Australian dollars for this trial. 96 people received a low dose, no adverse effects. The next 6 were given slightly higher dose. 1 of them died within 7 days. 4 people went into coma, and they've come subsequently. And this is a compound which is based on a natural product. You have to be careful. So what's our rules? Do no harm. Please be careful if you sign up for clinical trials, ensure they do no harm. That's our job as scientists, but it's also your doctor's job to recommend what's appropriate for you. So how do I bring a new drug to the clinic? So what do I need to do to produce a successful clinical trial to bring a new therapy to people living with Parkinson's disease? Well, Victor's raised many of safety. Have to be safe. We have to be accurately able to diagnose Parkinson's disease, even more so than in personal reasons, and I'll come to that in a second. But we've got no way of even assessing if a compound is working, because we've got very few clinical measures which are very precise. So we need this blood test, we need this MRI, we need this basic research to be able to track the progression of the disease and the disease accurately. And in the interim, we're going to use old drugs. Why are we going to use old drugs? I'll come to that. And we need better science. Now, this is a paper from 2016. And they looked at a 25-year study, and they found that doctors have not improved their clinical diagnostic skills in the last 25 years. Non-expert, non-movement neurologists get it right 74% of the time. So 26 people live their whole life thinking they've got Parkinson's and they don't. If you're a movement disorder specialist, you get it right around 80% of the time. And it goes up to about 83% if you come back to that neurologist a lot. Now that's okay for the old world. But for us as scientists, how can I take a population of people, 8 out of the 10 have got Parkinson's disease, but those 2 don't. So my clinical trials are going to be skewed. We're going to have people which don't respond the same as anything else, and that may be a reason why some of the clinical trials haven't worked up to date. So there's a lot of effort on this clinical diagnosis. It's not just clinical, it's a selection of patients. Okay, so I've told you clinical trials cost a lot of money, $2.5 billion. So we're going to take a shortcut. We're going to use old drugs, repurposing old drugs. Why would we do that? Well, here's one. This is, let me take you through the title. Targeting chelatable iron as a therapeutic modality in Parkinson's disease. Okay, immediately obvious for everybody what that's about. No. Well, a chelator, and actually I think it's Greek, somebody will tell me, it means crab or claw-like, and what this molecule does is it grabs iron in this little pocket here. And a product which does that is deferriprone, and that's an old drug which has been used since 1994 for thalassemia. And David DeVoe, who's come out to speak to us in Australia and has said, well, he had this bright idea. He read this paper from 1924 and found that in people with Parkinson's disease, their brain has an excess of iron, so we can remove it and it might improve it, and he was right. If you look at the MRI, well, it's like looking at babies in ultrasound scans, but you can see there's a decrease in iron. First time ever a chemical has improved some of the markers of Parkinson's disease. But more importantly, now there's a clinical scale called the UPDRS, the United Parkinson's Disease Rating Scale. For the first time ever, a compound decreased the UPDRS. That means that people got better, and they got better for 18 months. It's the first time it's happened. Normally people increase their disability every 12 months by 4 points, but in this case there was a negative impact for 18 months. Remarkable. So using old safe drugs was a good way, and they're trying that now in a phase 2, a bigger study, to see if it's actually useful for the whole of the Parkinson's community. Better science. Well, we've got it wrong. We haven't got a cure in 200 years, so we must have it wrong in some ways. That's true. And then this, and I'm going to give you an example. Now, this is another long one, but I'm a scientist. I'm teaching a little bit about science. A beta-2 adrenergic receptor is a regulator of alpha-synuclein and the gene driving the risk of Parkinson's. Now look at this. They looked at 4 million people over 11 years. That is new science. That is big science. They came up with some remarkable findings. Victor talked to you about alpha-synuclein. I won't go on and more about it. What they did is really, really smart. They said, I'm going to take about a couple thousand drugs, or 1,200, 1,100 compounds that are being prescribed to people over the counter from your doctor. And we're going to screen it to see those compounds which reduce alpha-synuclein. Now, alpha-synuclein is, as Victor said, it's a genetic, the people with more copies of it get Parkinson's disease. And they found there were some compounds which did. And guess what they were? Salbutamol. I'm sure some of you have it in your pocket right now. Asthma medication. It's a puffer for asthma. So this was very nice and very theoretical. They then looked at those 4 million people. Now, this is the general population, and as time goes on, the more people get Parkinson's disease. So this is an inverted graph, so as we go along, more people get. But the people that took asthma medication since their age of 15 or 20, so this is designated daily doses, the more you took actually prevented Parkinson's disease. This is a mechanism which we did not know about until 2 years ago. Remarkable. But remember I said this word beta agonist? So the opposite to that is an antagonist, where it's opposite that. And propofol, is it propofol? No, propanol, is that right? Yeah, it's beta blockers. I don't know. That works opposite. So they predicted that it would increase the risk, and they found that it did. So here's the normal population here, and here is the increase. So this is a mechanism which we did not know about 2 years ago. So what people are doing now is see if asthma medication given therapeutically when on diagnosis will slow the progression of Parkinson's disease. And there are clinical trials which we know are going to come to Australia to look at this. And it's happening now throughout the world. Brand new science. We don't understand necessarily, we understand the mechanism, but we didn't understand the power of these old drugs. Another one. Mark Volquist is an Australian scientist working out at Monash. So one of the scientists not from the Florey I'm going to talk about. And he looked at another 800,000 people in Taiwan. Remarkable, big science, new science. And they found that people with type 2 diabetes had a doubling, a 2.2-fold risk of having Parkinson's disease. If they had another drug that was used to treat diabetes, that increased the risk even more. But they found that one drug, metformin, not only decreased the risk to that of the normal population. So this is another mechanism. So there are now clinical trials on this drug, metformin, to see if it progresses or prevents the onset of the disease. Because really what we want to do is when a person turns up to the clinic, you want to give a drug which slows the progression. It doesn't matter when they turn up to the clinic, even if it's advanced, it's our aim to treat everybody. And these types of drugs could do that. All right, so I've got 5 more slides. This is something that you can all do now, and this is more big science. If you go to the MJ Fox site, it's called Fox Insight, and they are aiming to get a couple 100,000 people to fill out their survey. They want people's living with Parkinson's experiences so that they know what are the symptoms which need to be treated first. This is happening now. You can participate in it. There's no harm to you. And then some people will be given genetic tests as well if you participate. So that's a really quite remarkable achievement by Michael J. Fox. The Cure Parkinson's Trust, you're probably not aware that they are currently undergoing, they've got 19 clinical trials for repurposed drugs. And all these leads which we've talked about are being investigated right now. And in the next few months, you'll hear advertisements about clinical trials on these repurposed drugs, and they'll be looking for volunteers for those. So you get in touch with your neurologists and you can participate in these trials. Now, Global Kinetics has a marvellous, what we call a gigalometer. It's a watch. This is a Florey invention. And what it does, it's like a smartwatch, and it helps doctors, and you saw Victor's talk about the fluctuation in drug over a day. It helps doctors tune the right amount of drug per person. And that's now been taken up by a company, Global Kinetics. Mal Horner is the inventor, who's a member of the Florey, and that's continually going through trial now. And Parkinson's Victoria is sponsoring a trial to help and train doctors and include participants. But this is a Florey invention which is being moving forward. If you want to participate, I'm sure if you speak to people, go to the Florey website, you may be eligible to participate in this trial. This is one which I've been working on for the last 15 years, and it's sponsored by a company called Prana Biotechnology, and they have now put the compound that we have been working on in the labs upstairs for the last 15 years into people for the first time. And I'm quite excited by this, and that's going through clinical trial for Parkinson's disease currently. And you can see that date's very new, the 4th of July 2018. Very exciting trials starting with these compounds. Another one, Cthulhu Adventures, has bought another Florey invention from Kevin Barnum, and I worked on this as well, for Parkinson's disease, and you can see these beautiful molecules which reduce oxidative stress and do many, many more things. But they are our inventions are being taken to the world by international companies, and we hope that these will be successful. I believe new science is hot on the trail. We're taking completely new approaches. We're taking with a priori, without any prior assumptions, and there's looking at like there's new advances. And I can say for the first time that I am confident that in the next 5 years, disease-modifying therapies will be starting to come on the market. And with that, I'll finish and call Victor up and we can answer some questions. Thank you.